In this video, we shall discuss briefly the pharmacology of opioid agents. In previous videos, we discussed how opioid agents act as analgesic agents. And in this discussion, we shall clarify certain terms. Terms such as opium, opiate, opioids, and endogenous opioids. Now, what you are looking at here is the poppy plant, the scientific name of which is Papaver somniferum. The unripe seed capsule yields a milky juice, which upon drying and powdering yields what is known as opium. Opium contains numerous alkaloids and other chemicals. An opiate is any compound structurally related to the substances found in opium. Now, these include natural and synthetic substances. The natural opiates include morphine, codeine, and thebaine, as well as papaverine. Now, papaverine is an opioid alkaloid isolated from the plant Papaver somniferum and can also be produced synthetically. Now, an opioid is any compound, regardless of structure, that has functional and pharmacological effects of opiates. Right. As we discussed in previous videos, we need to have a concept about the role of general anesthetic agents when we discuss about opioid analgesics as well. We discussed that the state of general anesthesia is said to be achieved when 5 components are present, including amnesia, immobility, decrease in autonomic reflexes in response to pain, analgesia, and loss of consciousness. We discussed that all these 5 components can be achieved by using a single general anesthetic agent. However, the dose that we would have to use would be too high, and that would cause hemodynamic suppression. And therefore, to achieve all components of the general anesthetic state without producing excessive hemodynamic suppression, we use a combination of drugs instead of a single general anesthetic agent. So we combine general anesthetic agents with neuromuscular blocking agents, opioid analgesics, and other agents as well. And the use of multiple agents to produce the state of general anesthesia is called balanced anesthesia. Hence, opioid analgesics are commonly used as a part of balanced anesthesia. So, opioid agents are commonly used in the operation theatre, in the emergency department, as well as intensive care units. Now, how do we classify opioid agents? We can classify them into classical agents, opioids used for opioid substitution therapy, fentanyl and its derivatives, opioids for post-anesthetic shivering, antitussives, miscellaneous opioid agents, antidiarrheal opioid agents, mixed opioid agonist, antagonist, and partial agonists, and other agents. Now, opioid agents that come under the classical agents include morphine and heroin. Opioid agents used for opioid substitution therapy include methadone and buprenorphine. Now, fentanyl and its congeners include drugs such as fentanyl itself, sufentanil, alfentanil, and remifentanil. The opioid used for post-anesthetic shivering include meperidine, also known as pethidine. Antitussive agents, which are of opioid nature, include codeine, noscapine. Miscellaneous agents include tramadol. The antidiarrheal opioid agents include loperamide and diphenoxylate sodium. Mixed opioid agonist, antagonist, partial agonists include nalbuphine, buprenorphine, butorphanol, and pentazocine. Another notable opioid agent is papaverine. Now, in addition to this, we also have pure opioid antagonists, which antagonize the effect of opioid agents. These include the antagonists with central action and those without central action. Those with central action include naloxone, naltrexone, and nalmefene, while those without central action include methyl naltrexone, naldemidine, naloxegol, and alvimopan. Now, opioids have various pharmacological effects. The pharmacological effects of opioids may be considered as useful or harmful depending on the situation. The point to be noted here is that pharmacological effects are not the same as the uses or indications of opioids. Both are completely different. Some pharmacological effects are useful, but some may be extremely harmful. So what are the pharmacological effects of opioids in general? On the GIT, they produce constipation. They can cause hyperprolactinemia. The action on urine output is variable, but there is nothing variable about the action of opioids on respiration. They are powerful respiratory depressants. They can produce euphoria or dysphoria. They are powerful analgesic agents. They produce sedation, and this is useful in the the conduct of various surgical procedures. Opioids produce significant amount of opioid tolerance and dependence. On the heart rate, they produce bradycardia. And in terms of alcohol craving, they make the patient more susceptible to alcohol craving. In terms of its effect on pupil size, opioids produce miosis. They have got antitussive effects. They cause contraction of the biliary smooth muscle, and they can also cause histamine release, which in turn leads to the associated phenomena such as pruritus, venodilation, fall in BP, and so on. And last but not the least, they can cause severe nausea and vomiting. Right. So, we have seen the many pharmacological effects of opioids. Now, how do opioids produce these effects? Opioids bind to their receptors and thereby produce their effects. So, the actions of opioids are receptor mediated, and there are three important receptors that we need to take into consideration. They include the mu opioid receptors, the kappa opioid receptors, and the delta opioid receptors. And these are the ways in which these opioid receptors are commonly expressed in medical literature. Now, let's move on to the prototype opioid agent, morphine. Now, we saw the many pharmacological effects of morphine. Now, when we consider the uses of morphine, morphine is most valuable as an opioid analgesic. So, does it produce constipation? Yes, it does. But morphine is not used as an antidiarrheal. Does it produce antitussive activity? Yes, it does. But morphine is not used as an antitussive. So, this is important to remember and understand. Morphine is a powerful opioid analgesic agent. It is valuable as an analgesic agent. It can also produce sedation, which is of great value while conducting various surgical and non-surgical procedures on the patient. And while it is true that morphine may have many other effects, they are not commonly used for such indications, such as antidiarrheal indication or antitussive indication and so on. They are mostly used as opioid analgesics and sedatives. Now, in addition to those uses, morphine also has got a unique use. It is very commonly used in the cardiac intensive care units for angina pectoris and acute myocardial infarction, particularly when it leads to left ventricular failure or acute decompensated heart failure. So we know that angina pectoris occurs when there is decreased myocardial oxygen supply or increased myocardial oxygen demand, or both. This angina can be relieved by reducing myocardial oxygen demand, and morphine decreases preload inotropy and chronotropy, and thereby it reduces myocardial oxygen demand. Morphine has not been demonstrated to improve outcomes in patients with acute coronary syndrome, but because it does reduce preload inotropy and chronotropy, and because of its powerful analgesic effect as well, morphine is very commonly used in acute coronary syndromes. Yeah, so we already discussed the mechanism of analgesia of morphine and other opioids at the supraspinal and spinal levels. We discussed the pharmacological effects of morphine and other opioids in general. We discussed the uses of morphine in particular, and we also discussed the special use of morphine in cardiology. Now, what are the adverse effects of morphine and what are the contraindications of morphine? When we discuss about the contraindications of morphine, we commonly mention about patients with head injury. Theoretically, morphine is contraindicated in patients with head injury for 3 reasons. Number 1, morphine can increase the intracranial pressure. Number 2, it causes respiratory depression. And number 3, the administration of morphine to a patient with head injury can interfere with the monitoring of this patient. This is because morphine can cause miosis, vomiting, and altered consciousness. The examination of the pupils are critical in the assessment of patients with head injury. Normally, the pupils should be equal in size and should react to light. And a common statement that is written on the charts of patients with head injuries is the term PEARL, whereby on examination the pupils are equal in size and react to light. Now, any disparity in pupil size could potentially indicate catastrophic brain trauma. So, when a drug is administered to a patient which interferes with the pupil size, this could make clinical assessment of such patients very confusing. Projectile vomiting is a sign of increased intracranial pressure, possibly due to a bleed. But vomiting can also be caused by opioids. And again, in this way, opioids can interfere in the assessment of the patient. Now, coming to opioid analgesia. Opioid analgesics are extremely effective and powerful, but we cannot prescribe them commonly. This is because they have multiple unwanted effects. And the 2 main adverse effects that limit the widespread use of opioid agents as analgesic drugs are respiratory depression and addiction. Non-steroidal anti-inflammatory drugs do not produce respiratory depression and when used properly rarely cause addiction, and therefore they are the most logical alternatives to the opioid analgesics, at least for moderate or mild pain. Yeah, so we discussed in detail about morphine, its mechanism of analgesia, its pharmacological effects, the indications of morphine, its special use in cardiology, its adverse effects, and contraindications. Heroin is the next classical opioid agent. It is extremely addictive, and therefore the pharmacological uses of heroin are almost non-existent. We will continue this discussion about the pharmacology of opioid agents in the next video.